Good evening, everyone. You are welcome to the second session for this lecture on peptic ulcer disease. And today we'll continue with other aspects of the lectures, which include the etiology of peptic ulcer disease, the classification of ulcers, clinical features, complications, differential diagnosis, and the investigations. Now, the etiology for peptic ulcer disease is usually multifactorial. There are several factors combined that cause peptic ulcer disease. However, the identified and most common and important risk factors are noted to be Helicobacter pylori infection, which is recognized as the most important etiology for peptic ulcer disease, non-steroidal anti-inflammatory drug use, smoking, stress, alcohol ingestion, genetic factors, as well as other medical conditions like Zollinger-Ellison syndrome. These are some identified etiology for peptic ulcer disease. Helicobacter pylori infection, as we mentioned, it's the single most important etiological factor for this condition. And H. pylori is a gram-negative, spiral, motile, microaerophilic flagellate. It's urease and peptidase producing bacteria. These particular features of being flagellate and urease makes it adapt to the environment and also able to cause the pathology in the stomach. Now, it is found in more than 90% of patients with duodenal ulcer and 80% in patients with relapse of the disease. More than 90% of Helicobacter pylori colonizes the antrum of patients with peptic ulcer disease. As we mentioned yesterday, that more than 50% of the world population are infected with this bacteria. It colonizes the alkaline mucosal layer over the epithelium and causes chronic active inflammation. This ultimately leads to atrophic gastritis type B, and atrophic gastritis type B is associated with 75% of gastric ulcers. Helicobacter pylori stimulates gastrin release from the G cells of the antrum and thereby increase acid secretion. They also produces mucinase, and this mucinase disrupts the mucous protective barrier of the stomach and the duodenum. Now, how do they adapt in surviving the high hostile environment of the stomach? They produce urease, which converts urea. This urease converts urea into carbon dioxide and ammonia, which buffers the acid environment before it burrows deep into the surface mucosa. Now, in the lumen, it has to survive the hostile environment. Okay. The urea that is produced by the cell within the stomach is being broken down to release ammonia and carbon dioxide. The ammonia will buffer the acid, and the organism will survive in that hostile environment before it finally, with the aid of this, its flagella, it moves into the mucosa. Now, this organism is transmitted by oral or fecal-oral route. Now, aside H. pylori, NSAID is also a notable etiological factor for peptic ulcer disease. Chronic use of NSAID increases PUD by 5-fold. It increases the risk of peptic ulcer disease by 5-fold and upper GI bleeding by at least 2-folds. More than half of patients presenting with bleeding report recent use of NSAID. When you take their history, you will find a recent use of NSAID before they present with upper GI bleeding. Many of these patients remain asymptomatic until they develop a life-threatening complication. And usually, the risk is higher in patients that are more than 60 years. And usually when you see elderly patients, because of several comorbidities like arthritis, body pain, they abuse NSAID, which makes them have risk. And this is even worsened if they are on anticoagulants and they have bleeding tendencies. They present with massive upper GI bleeding that may even warrant surgical intervention. Now, other factors like smoking, stress, physical stress, and other factors. Smoking increases gastric acid secretion and duodenogastric reflux. When there is a bile reflux into the stomach, it worsens the risk of developing gastritis. So it also decreases the mucus production by inhibiting prostaglandin production, as well as pancreaticoduodenal bicarbonate production. So with this, cigarette smoking increases the risk of peptic ulcer disease. Patients that are smokers tend to have increased risk. They are fold for developing, they have 2 times risk of developing peptic ulcer disease than non-smokers. Physical stress following surgery trauma may lead to acute stress ulcers in the first few days on exposure to stress. Cushing ulcers are associated with CNS diseases, while Colon ulcers are associated with burns, especially major burns. And usually these burns can, when they are major burns developing colon ulcers, they may even present with massive upper GI bleeding. So the common etiological factors you should remember: H. pylori infection, okay? H. pylori, NSAIDs, stress, physical stress, and other factors. Some genetic factors will increase, some patient will have family history of peptic ulcer disease where they will have increased acid output production, or they may have increased parietal mass in the stomach, and they will have increased risk of developing peptic ulcer in the family. Now, how is PUD classified? Peptic ulcer disease can be classified as acute or chronic PUD. They could be classified based on the location as gastric ulcer, duodenal ulcer, or it could be a form of acute exacerbation of peptic ulcer disease. And you should know that both the gastric and duodenal ulcers present with acute and chronic form. Now, when you say a patient has an acute peptic ulcer disease, there is a sudden onset of erosion of the epithelial lining, and this is often associated with NSAID use. It is also seen in critical conditions associated with hypotension, stress, and erosive gastritis. Usually, the patient is not a known peptic ulcer disease, but there is a precipitant which might just cause a patient to develop an acute onset ulceration of the epithelial lining. While chronic peptic ulcer disease is a long-standing with ongoing presence of ulcer in the stomach or duodenum. And it is the chronic peptic ulcer disease usually that has the multifactorial etiology, as we mentioned, where you will see patients having a lifestyle that involves smoking, alcohol ingestion, infection with Helicobacter pylori, okay? They might also be a genetic factor, and several other multifactorial etiology are seen in patients with chronic peptic ulcer disease. Acute exacerbation of PUD, there is a sudden worsening of symptoms or complication of an existing ulcer. Now here, the patient will have history of peptic ulcer disease in the past, but the symptoms are either mild or they are even asymptomatic. However, they have history of PUD. And usually this will now be associated with a trigger. When a patient takes in something that will trigger that, like coffee, strong tea, NSAID, and they now have an exacerbated symptoms. Now, it could, as we mentioned, it could be gastric ulcers or duodenal ulcers. Now, clinically, it is important you should be able to differentiate gastric ulcers from duodenal ulcers, even though you have the symptoms not clearly distinct. The difference can ultimately be made using an upper GI endoscopy, but however, you should still have an idea in differentiating gastric ulcer from duodenal ulcer. You should know that gastric ulcers develop in patients with chronic atrophic gastritis with low or normal gastric secretion. Now, this is a difference. Gastric ulcers, a risk here is atrophic gastritis. The basal acid output is low or normal, while in duodenal ulcer, it's developed in patients with well-developed gastric mucosa and increased acid secretion. Gastric ulcers are more common in patients with blood group A. Now, when you are taking clinical history of a patient with PUD, you often ask of their blood group because gastric ulcer is commoner in patients with blood group A, while duodenal ulcer is commoner in patients with blood group O. Gastric ulcers are more common in laboring class, while duodenal ulcers are evenly distributed throughout the social class. So the working class are more prone to gastric ulcers than duodenal ulcers. Gastric ulcer is commoner in older age group, like 45 to 65 years, while duodenal ulcer reaches peak incidence at 35 years. Now, close relative of patients with gastric cancer are more likely to develop gastric than duodenal ulcers. Sorry, gastric ulcers. Now, you should know that there's a term called the giant gastric ulcers and giant duodenal ulcers. Now, you should know that giant gastric ulcers are ulcers that are greater than 3 centimeters, while giant duodenal ulcers are ulcers that are greater than 2 centimeters. Now, the significance of knowing a giant ulcers, especially the giant gastric ulcers, they are ulcers that are prone to malignancy. They are prone to malignant transformation. Now, when you see ulcer in the stomach that is greater than 3 centimeters, and it is located in the greater curvature, these are risks for malignancy because, as we mentioned yesterday, the ulcers are more prone to develop in the lesser curvature. Now, these are atypical features. They are giant, and as well, they are located in area that is even more vascularized, which is unlike the usual pathophysiology of the ulcers. Now, this is the modified Johnson's classification for gastric ulcers, and this is very important, you know, because this classification, it classifies gastric ulcers into 5 types. And this is by location, acid secretion status, complication, and the incidence for the ulcer. You should know that the modified Johnson's classification, it classified the gastric ulcers into type 1 to 5. Now, the type 1 is the commonest type. Type 1 gastric ulcers is the commonest type of gastric ulcer. It is located in the body and the lesser curvature. Now, it is important you pay attention to the acid output of these types of ulcer because it is only the type 2 and the type 3 that are associated with high acid output. So type 1 is located in the lesser curvature. The acid hypersecretion is nil, and the complications, bleeding is uncommon, and it is the commonest type, and the incidence is 55%. So this is type 1 gastric ulcer. It is in the body close to the lesser curvature. Now, and of course, for obvious reason, you know gastric ulcer are commoner because of, in the lesser curvature, because of the precarious blood supply to that area in the submucosal plexus. Now, type 2 is located in the stomach and the first part of the duodenum. It is located in the stomach and the first part of the duodenum. You should know this is the type of one of the type of ulcer that is associated with what? Hypersecretion. Take note. Type 2 and type 3 are the types of ulcers that are associated with hyperacid secretion. Now, complication rate, bleeding, perforation, as well as obstruction are common. These are the 3 common complications of peptic ulcer disease, and these are in order of frequency. Bleeding is the commonest, followed by perforation, then obstruction. Now, type 2, the incidence is 20%. And this is what? In the body and the first part of the duodenum. Now, type 3 gastric ulcer is regarded as the pre-pyloric ulcer. Pre-pyloric ulcer. And it's also associated with acid hypersecretion. The complications that are commonly associated with type 3, the pre-pyloric ulcers, are bleeding and perforation, and the incidence for pre-pyloric ulcers are 20%. Now, type 4. Type 4 is high on the lesser curvature, close to the cardia. Now, you can see type 4 is not associated with acid secretion, and the common complication that is associated with type 4 is bleeding. Okay, and the incidence is less than 5%. Now, type 5 is ulcer anywhere, but is NSAID induced, medication induced ulcer, and the ulcer is found anywhere. And the complication, it is not associated with hyperacidity. The complications that are related to this type is bleeding and perforation. Now, the incidence is less than 5%. Now, the take-home message for modified Johnson's classification, 1, you should know is 1 to 5. 2, you should know the commonest type is type 1. 3, you should know type 2 and 3 are associated with hyperacidity. And you should know that type 5 is drug-induced, which is commonly NSAID-induced ulcers. Now, what is the clinical manifestations of ulcers? More than 90% of patients with peptic ulcer disease will present with abdominal pain. And the characteristics of this abdominal pain is burning in nature, stabbing or grinding in nature. It is precisely an epigastric pain or right hypochondrial pain, but may be high in the chest, retrosternal, or it may be as low as around the umbilicus, but classically they present with an epigastric pain. Now, typically it is described as a non-radiating pain, however, may radiate to the back, okay, in penetrating gastric ulcer involving the head of the pancreas. Usually, this pain is described as a non-radiating pain. However, it could radiate to the back when it has penetrated to involve the head of the pancreas, which is the common organ that is involved on the bed of the stomach. Now, referral to extra abdominal site is uncommon. Now, when we say it's typically non-radiating, it doesn't mean you won't find some patient complaining of pain, epigastric pain that radiates to the back, even if this is not associated with penetration into the pancreas. Now, you should know that duodenal ulcers, the duodenal ulcer pain are periodic, okay? They may be symptom-free for a very long period. Maybe they have symptoms. Then over some period, like some months, they will be symptom-free. Then they now develop symptoms again. This is a characteristic of duodenal ulcer pain. It is described as pain, ulcer pain with what? Periodicity, which is unlike the gastric ulcer pain. So duodenal ulcer pain is periodic, often experiences pain 2 to 3 hours after meals, okay, or at night. And the pain may awaken patient at night in 2/3 of patients. Now you should know that after patient ingests meals, the meals have been mixed, okay, into chyme semi-solid. As it moves into the duodenum, the acid content will irritate the ulcer and they will have pain. So this is classical of duodenal ulcer. That's why the pain will occur 2 to 3 hours after ingestion of meals, or maybe the patient has even gone to bed and the pain will awake them at night. And you can see up to 2/3 of this patient will have pain that awakens them at night. Now you should know that the pain of gastric ulcers occur with eating or shortly after meal and is unlikely to wake patients at night. Immediately after this patient feeds, okay, there is irritation of the ulcer. As they feed, the acid output increase and it irritates the ulcer, they have pain. This pain can be so severe sometimes, and patient might even vomit to feel relief of the pain. Now, the pain is relieved by antacid in duodenal ulcers, but minimal relief is seen with gastric ulcers. You should know patients that commonly have relief from this dyspepsia after taking antacids, okay, is commonly seen in what? Duodenal ulcers. However, the pain that patients for gastric ulcers, the pain is not commonly relieved, even though if they have relief, it's just minimal relief, unlike the duodenal ulcers. Now, you should know that hunger aggravates the pain as more acid is secreted to irritate the ulcer. So these are the various characteristics of pain, which is the commonest presenting feature of a patient with peptic ulcer disease. Now, you should know that duodenal ulcers is about twice commoner in males compared to females. But the incidence of gastric ulcer is similar, okay? Now, there is no sex difference between, there is no sex difference in gastric ulcers. However, you should know that duodenal ulcer is twice commoner in males as compared to females. Now, regarding weight loss may be associated with what? Gastric ulcers. Why? Because when they eat, it triggers pain. Sometimes they might have to even trigger vomit to feel relief of the pain. Now, this makes the patient have fear for food, and patient will now lose weight. Unlike duodenal ulcers, they tend to gain weight because feeding tends to relieve, immediate feeding tends to relieve the dyspepsia they have. Now, if they are bleeding, they will tend to present with Melina's stool. You should know that nausea, bloating, and features of anemia may be other features of peptic ulcer disease. During physical examination, you might not find any sign, except in acute attack, where you may have epigastric tenderness. Now, you should know in a patient with gastric outlet obstruction, they may have secussion splash. Complications like gastric outlet obstruction, they may have secussion splash. You will demonstrate secussion splash. You might, the GOO is described as a stomach that you can see, you can feel, and you can hear. Now here, when they have GOO, you will see a visible peristaltic wave that is moving from the left side to the right of the abdomen, okay? You may palpate an epigastric mass, and you can demonstrate a secussion splash. Now, what are the complications of peptic ulcer disease? The three most common complications of peptic ulcer disease in decreasing order of frequency are bleeding. Bleeding is the commonest complication, upper GI bleeding. They may present with massive upper GI bleeding, okay? They may present with perforation and generalized peritonitis, and the obstruction here is gastric outlet obstruction from chronicity. Now, the gastric outlet obstruction may be from edema around an active ulcer, okay? Or it may be from chronicity and fibrosis. And this fibrosis will lead to narrowing, and this is called cicatricial polarization of the duodenal opening. So they will now present with GOO, but you should know that the commonest complication they have is bleeding, followed by perforation, then obstruction. Now, we mentioned yesterday that the bleeding usually occurs in the first part of the duodenum. Now, the ulcer is located posteriorly in the first part of the duodenum. That is where bleeding. And when the ulcer penetrates and erodes into the gastroduodenal artery, they will have torrential bleeding. Now, for perforation, usually it could be gastric perforation, it could be duodenal perforation that occur in the first part of the duodenum, but here it is located anteriorly. You should know that bleeding occurs posteriorly in the first part of the duodenum commonly, while perforation occurs anteriorly in the first part of the duodenum. Now, what are the differential diagnoses of peptic ulcer disease? Now, patients with peptic ulcer disease, the differentials may include carcinoma of the stomach. However, in carcinoma of the stomach, the duration of symptoms is shorter. It's usually less than 6 months because malignancy have shorter duration compared to benign lesions. And the pain is not burning epigastric pain as in peptic ulcer disease, rather it's a dull epigastric pain. And anorexia and weight loss are prominent features in carcinoma of the stomach. Anorexia and weight loss are very prominent, unlike peptic ulcer disease. And you may palpate a mass, okay? Now you should know that usually when you see a patient greater than 50 years presenting with, one, you should know that it's more than 50 years. Two, recent onset dyspepsia, okay? Recent onset dyspepsia, as well as weight loss and anorexia. You should be thinking of malignancy. Okay, these features are common with malignancy. Greater than 50 years, recent onset dyspepsia, weight loss, and anorexia. Now, gallbladder disease is also a differential diagnosis. They may present with features similar to peptic ulcer disease. However, this patient will be having, to differentiate it, patient will be having flatulent dyspepsia. Flatulent dyspepsia as a symptom is very prominent, meaning they will have dyspepsia with excessive belching. They will have right hypochondrial pain, usually after fatty meals. Pain radiates to the back and often referred to the right shoulders. There is an attack of biliary colic and jaundice. Sometimes this patient might have cholelithiasis, stone, which may block the common bile duct, and they will present with biliary colic and jaundice. Now, reflux esophagitis. When a patient is having reflux and esophagitis, there is a burning pain behind the sternum. Here they have more of chest pain, which is worsened when they lie flat or when they bend in a recumbent position. Now they will have water brush, where they have reflux of stomach the acid, hyperacidity, into the mouth to mix with the saliva. So that is what water brush. Now, another differential diagnosis is chronic or recurrent pancreatitis. You should know patients with pancreatitis have burning epigastric pain that radiates to the back, and it's not relieved. Unlike peptic ulcer disease, it is not relieved by antacids. And this pain is relieved by leaning forward, okay? It is aggravated by lying supine. Because when they lie supine, the intestine tend to compress on the inflamed pancreas and they will have pain. When they lean forward, the intestine is displaced from the inflamed pancreas and they will have relief. Now they may have steatorrhea. Carcinoma of the transverse colon. Now, for carcinoma of the transverse colon, they may present with epigastric pain, dyspepsia, but however, the history is short because it is malignancy, and they have change in bowel habits because it is the large colon that is involved. They may have bleeding per rectum, and you may palpate a mass in the epigastric region. Patient with liver cirrhosis may be a differential diagnosis. Why? Because they may have an associated duodenal ulcers. Patient with cirrhosis may have associated duodenal ulcers, and the liver may be palpable. Now, intestinal parasitemia, they may have dyspepsia and anemia. Now, some patients may be having a non-functional dyspepsia, okay? Non-ulcer dyspepsia, it's called functional dyspepsia. Features of PUD with negative features on evaluation. When you evaluate them, they have all the features of peptic ulcer disease. Upon evaluation, you will not find any ulcer, okay? That is called functional dyspepsia. You do an upper GI endoscopy for them and you will not find any feature of ulcer. However, they are presenting with symptoms of PUD. Patient may be taking irritants like alcohol, strong tea, coffee, or spicy meals, and they will now be presenting with features of dyspepsia anytime they take these triggers or irritants. Now, we'll talk about the investigations. Now, you should know the gold standard for diagnosis of peptic ulcer disease is upper GI endoscopy. It is diagnostic because you visualize the ulcer, and is the procedure of choice. The stomach and duodenum is visualized and the ulcer is detected. When you do an upper GI endoscopy, you look at the stomach and the first part of the duodenum, okay? Then you will characterize the ulcer, mentioning its location, okay, the feature of the ulcer, the size. Then you take biopsy. Biopsy is taken for histology as well as bacteriology for H. pylori infection. Now, this upper GI endoscopy has replaced the use of barium meal, even though barium meal was previously the investigation of choice. However, most centers have replaced the use of barium meal with the advent of upper GI endoscopy. It is more accurate in the diagnosis. Now, barium meal is over 90% accurate. You can have accuracy of up to 95%. Now, the double contrast barium series, upper GI series, is preferred. Why double contrast? You use the barium as well as air. It's double contrast. And the reason, this air will clearly outline the mucosa. It will outline the mucosa of the stomach and the duodenum. Now, what is the finding? The pathognomonic sign for ulcer is what? Ulcer crater. You will see an ulcer crater, okay? If this is the mucosa, You now see a what? A crater along the mucosa wherein the barium contrast will fill. Okay, that is pathognomonic for the diagnosis of ulcer in the stomach or the duodenum. Now, you should know that this crater may not be detected because of fibrosis from chronicity. You might have inability to pick these craters because of deformity from the chronicity. Now, the trefoil deformity of the duodenal cap or pseudodiverticulum are other features. Now, sometimes when you do this barium meal, okay, at the duodenal cap, which is the commonest site, you'll see what is called trefoil deformity. Okay, the ulcer is here. Then you now have something like this, bulges like diverticulum. Okay, sometimes they may appear like this. This shape is called the trefoil. This is the ulcer. The chronicity and inflammation will make it to pick up this shape, and you see contrasts. So this is called a trefoil deformity. Or you could even see a pseudodiverticulum. These are other features. So most importantly, you should know for barium studies, the double contrast is preferred. Secondly, the pathognomonic feature you are looking for is ulcer crater, which may not be seen, and you may see trefoil deformity of the duodenal cap and pseudodiverticulum. Another investigation is detecting the H. pylori infection, and this can be achieved via non-invasive method or via an invasive method. The non-invasive method entails doing a serological test, and this gives only 90% sensitivity and specificity. So you just take the blood sample and subject it to serology. If there's H. pylori, you get a positive result. Another test is the urea breath test. You remember when we are describing the characteristics of Helicobacter pylori, we said it's a urease producing organism. H. pylori is a urease producing organism. Now, this urease, what does the urease do? It will split urea. Urease will split urea into what? Carbon dioxide and ammonia. And this ammonium, it serves as buffer. So because of this urea splitting ability, the urea breath test is done, where ingestion of carbon isotope labeled urea is ingested. Okay, then the H. pylori will split the urea to give carbon dioxide. And you remember, the carbon dioxide here is labeled. Okay, and this labeled carbon dioxide that is produced will now be detected in the expired air. So when there is detection of the carbon dioxide that is labeled, it means the H. pylori is present and it is splitting the urea. Now, this urea breath test is used to monitor treatment, because if you are treating patient with H. pylori and you give urea breath test, it's not producing, it's not splitting the urea to form the carbon dioxide that is labeled, you know it has been eliminated. You can do stool antigen test, but this one is it's having a high false positive test because it takes longer to become negative even after eliminating the H. pylori. So detection of H. pylori, you should know the non-invasive tests include serological tests, the urea breath test, as well as the stool antigen test. Now, the invasive, you still need to do an upper GI endoscopy and take multiple biopsies. After taking multiple biopsies, then you now subject it to rapid urea test or even histological staining. Okay. Now, other general investigations are done, like full blood count, okay, stool occult blood, stool microscopy for worms. So this, we are going to stop here. If you have any question, okay, you can ask. We'll stop here. Tomorrow we'll continue with the treatments, both the medical and surgical treatment of peptic ulcer disease. So if you have any question, okay, you can unmute yourself, then you ask. Thank you very much for listening. Any question? Okay. So it appears we don't have any question. So in the absence of any question, we are going to end the meeting here. Tomorrow, God willing, we are going to discuss on the treatment, medical treatment, and all the surgical options for treating peptic ulcer disease. So thank you very much. We are going to end the meeting now.
Thank you, sir.